Dr. Stylianides is from the Cleveland Clinic, which is the second largest GSD center in the States. Pretty impressive. She is an endocrinologist and trained under Dr. David Weinstein, as she mentioned, and has a lot of experience in GSD, has several publications. So I'm excited for all the knowledge she will share with us today.
Hi guys, thank you for having me here to talk to you today. I'm really excited to be here. This is one of my favorite things to talk about. So people who know me well know better than to even get me started. So I'm very excited that you guys are interested in hearing about this. So our objectives for today will be to discuss the dietary guidelines and sugar restrictions associated with each of the hepatic forms of GSD, to understand the physiologic basis for the nutritional management of each type of GSD that we're going to talk about, and to be able to apply this knowledge to prevent the metabolic derangements that occur and the potential long-term complications that we know are associated with metabolic control. So a little bit of background about glycogen storage disease. Type 1 in particular, which is called type 1 because it was the first type discovered, was considered to be a fatal disease before 1971. So when a baby was born and diagnosed with this condition, parents were generally told there's no treatment and there's nothing we can do. So make your baby comfortable and don't expect that they will live very long. So today there's a number of patients in their 30s, 40s, and even 50s whose parents were told that, but for whatever reason, some of these people got lucky and they survived anyways. But to be honest, not that many. I don't know of many 50-year-olds with this disorder, but a lot has changed since then. So it was in the early 70s that it was discovered that a continuous supply of glucose could correct the metabolic derangements that would occur with hypoglycemia. So with this knowledge, people with GSD type 1 could now be kept alive, but they certainly weren't thriving because we had a lot to learn about how to treat this disorder. So it was in 1982 that it was first discovered that uncooked cornstarch could be used as a continuous supply of glucose, as opposed to something that had more complications associated with it, like TPN. And with this discovery, the prognosis of the disease improved dramatically. So a lot has changed over time. Argo is now available in supposedly a no-mess plastic container, but it's still pretty messy. And here's one of my favorite Halloween costumes. This is actually the child of a woman who has GSD type 1B. So the next major breakthrough in the treatment of this disorder came 30 years later after cornstarch was first discovered. So once it was discovered that people could be kept alive by taking cornstarch around the clock, it was still a very difficult disease to live with. Because for type 1 in particular, a dose of cornstarch generally wouldn't last longer than 4 hours, and patients still had to wake up in the middle of the night every night to take their cornstarch. And if they didn't, they would potentially have life-threatening hypoglycemia. So in 2012, glyphosate extended release cornstarch became available for use in the United States in patients older than 5. And for many people, this was life-changing because it allowed them to sleep through the night for the first time. So I'm going to come back to this slide a few times throughout the talk. This is kind of a condensed version of some of the reactions of glycogenolysis and some other metabolic processes. And there are many steps that have been skipped, so this is kind of simplified. But I just want to use it to illustrate where the defect is in different types of glycogen storage disease that we're talking about, and relate that to some of the metabolic abnormalities that we see in each type. So this is just a diagram that kind of shows where all of them are, but we'll go through each of them individually. So starting with glycogen storage disease type 1, you can see this is a problem with the enzyme that converts glucose 6-phosphate to glucose. And there's no steps skipped there. So this is just the enzyme glucose 6-phosphatase, which is involved in the final step of glycogen breakdown. And that is also the final step of gluconeogenesis, so making glucose from non-glucose substrates. And what you can see, so imagine blood sugar starts to go low. The body has many ways to try to raise blood sugar because it's the preferred source of fuel for the brain. So many hormones are released that will try to raise blood sugar, and some of them work by telling the liver to release its glycogen stores. So if you have GSD type 1 and you're missing the enzyme needed for that very last step, what you end up with is excess glucose 6-phosphate. And so if you imagine this is kind of like a road map, and you have a roadblock right there, all this glucose 6-phosphate that you're creating by trying to break down glycogen, it's not going to raise your blood sugar, but it will form excess uric acid, lactate, and lipids because there's no block in those pathways. So these are the classic laboratory abnormalities that are pretty typical in type 1, high triglyceride concentrations, high lactates, and high uric acid. So how do we treat this disorder? There's this equation that comes from a very old paper that estimates hepatic glucose production rates. And I actually have an Excel file that has this equation programmed into it so that I can plug in a patient's weight and it'll tell me grams of glucose per hour. And I use that to start a dosing regimen. So most patients with type 1 require doses of cornstarch about every 4 hours. The younger patients, like infants, for example, often can't go longer than 3 hours. In some rare cases, adults can last 5 or 6 hours overnight, but generally that's not ideal, and it's not going to maintain normal blood sugars and normal lactates for that entire period. So what I do is I start with this Excel file that I have, and I use their ideal body weight to figure out what is their glucose requirement in grams per hour. And I might multiply that by 4 and say, well, let's start with this dose every 4 hours and see how it does. The way that I like to manage this after therapy has been started is to kind of individualize it to the patient. So I bring patients into the hospital for an overnight visit, and I measure their blood sugar and their lactate every hour while they're on this cornstarch regimen that I think might reasonably work well for them. And I test it to see if it does. So I want to see blood sugar and lactate stay normal all the time. And if it doesn't, then I can get a sense of where I might need to increase or decrease doses or change the interval based on what is abnormal. And then the goal is to keep blood sugar normal all the time so that your liver is never trying to release its glycogen and making the triglycerides and the uric acid and the lactate. So glycosate is very, very helpful in type 1A particularly. It can be used in any type where an overnight dose of cornstarch is required, and that can occur in other types as well, but it almost always does in GSD type 1. So for that reason, I think it's really had the greatest impact in people who are affected by that disorder. So when I start a patient on glycosate, I prefer to do that inpatient, although I have had some patients do it as an outpatient because I see patients from all over the country. And it's not always possible for them to come to Cleveland to do this. But it's preferable if they do, because we come up with a starting dose of glycosate, and then we test it the same way that I test regular doses of cornstarch by measuring hourly blood glucose and lactate levels with the goal of keeping them normal. So the dose of glycosate required is generally going to be much bigger than Argo. With Argo cornstarch, you can't just keep increasing the dose and expecting it to work longer and longer. But with glycosate, you can. So one way to start this is to take the bedtime dose that they usually take and the middle of the night dose that they usually take and just add those together and give that number of grams of glycosate. So if those two separate Argo doses were working well, then it's very possible that that dose of glycosate would work well also. Kind of an average adult dose of glycosate for patients with GSD type 1 is 135 grams. So if you're starting with an adult, that might be a good place to start. Okay, so all types of GSD, part of treating them involves limiting sugar. And if you have type 1, the restrictions are even more strict than any other type. With any type of GSD, simple sugar can increase glycogen storage in the liver, with the exception of type 0, which we'll talk more about. And so you want to avoid sugar in any type because you don't want to make the liver bigger, full of glycogen. But in type 1 in particular, there's certain sugars that their body just can't use. So galactose and fructose are the two monosaccharides that they can't use. So here's more of the pathway that I showed you before with some of the steps that were omitted. Now you can see them here because I wanted to show you how galactose can get into that liver and be converted to glycogen. Fructose can do the same thing, but they can't come back out as glucose because that would be gluconeogenesis, creating glucose from a non-glucose substrate. So in these patients, dairy should be completely limited, any kind of dairy that has sugar in it, that has lactose. And then the same goes for fructose. So they need to avoid fruit as well. So this is a very limited diet. And because it's so limited, a multivitamin is always required. And most likely they're going to need calcium supplementation because they're probably not going to meet calcium requirements from their diet. The specific sugar restriction that I ask them to do is to limit total sugar to less than 5 grams per meal or less than 2.5 grams per snack, and be even more restrictive with fruit sugar and dairy sugar. So infants with type 1 are a little bit more difficult to manage because they're generally not able to digest cornstarch. The enzyme that they need to digest it, amylase, just generally isn't very mature until at least 6 months, and in many of them, up to a year. So the goals of treating an infant with GSD type 1 are to maintain normal growth, maintain adequate vitamins and minerals, and this is generally achieved by frequent feeds during the day, and sometimes continuous overnight feeds are required. Many infants with GSD type 1 have a G-tube because, of course, they have almost the most severe hypoglycemia. It's life-threatening. And an infant who isn't tolerating feeds because of illness or just refusal could potentially be a life-threatening situation. So many of them do have G-tubes. And if frequent feeds around the clock isn't maintaining normal blood sugars, then oftentimes they do end up on continuous feeds until cornstarch can be started. So generally we use Enfamil Prosobi formula. Any soy formula is going to be lactose-free. So that one is pretty common. And then Tolerex is a great formula for sick day management because it's more concentrated. So if you have a G-tube and an infant who's vomiting, sometimes just a very slow infusion of Tolerex can prevent a hospitalization or a severe hypoglycemia. If for whatever reason Prosobi or another soy formula isn't tolerated, then you can use some of the more elemental formulas, Nutramigen, Vivanex, Elecare. So as I mentioned, infants typically don't tolerate cornstarch until at least 6 months, and many not until a year. When I start cornstarch in infants, if I'm going to start with somebody in that 6 to 12 month range, I'll start with very, very tiny doses that I know aren't going to affect their blood sugar. But what I'm trying to do is just upregulate amylase so that eventually I can get them to a dose that is going to keep their blood sugar normal. So I might start with something like 2 grams measured on a gram scale, put in a bottle 3 times a day, and do that for about 3 or 4 days, keeping an eye out for like fussiness, abdominal distension, cornstarch in the diaper, sometimes you'll see that, or just diarrhea. If those things aren't happening in a few days, then I might go up by a gram or 2, and just keep slowly adjusting every 3 or 4 days as long as there's no symptoms of intolerance. Most infants who are about a year old, I can tell you from that Excel file that I mentioned where I have the formula that will give me estimated glucose requirements. For an average size infant, 1 year old, that works out to be 4.5 grams of glucose per hour. And for many adults, it's 10 to 11 grams of glucose per hour. And those are the only two that I have memorized. Otherwise, I always use that Excel file. But so generally for a 1 year old baby, once you get up to doses of about, if you're doing every 3-hour dosing, then maybe 12 to 15 grams might last that amount of time. So sick day management is sometimes very difficult. Tolerex can be used sometimes to prevent severe lows, hopefully prevent kids from needing to go to the hospital. But they should also have an emergency letter that details exactly what labs are needed, what fluids should be used, what rate, because it's very likely that the emergency care doctor is not going to be familiar with GSD. Feeding aversions are common in infants with type 1 for a number of reasons. Number one, they don't have a chance to get hungry, so they never learn normal hunger signals. So a lot of times a feeding team is required to help overcome that, and it can take months to years. So sometimes it can be a really difficult thing. And kids do often struggle with poor appetite because you're giving them so many calories from cornstarch, and they are empty calories. So it's important that the food in their diet is really nutritionally dense. I try to start overnight cornstarch therapy as soon as I possibly can, mostly because I feel like it's a safer way to treat GSD. So I've heard too many stories of infants who are on continuous feeds, and for some reason the feed got abruptly discontinued. And for whatever reason, there wasn't an alarm that went off because it was a pump malfunction or something like that. So maybe the med port came open and the feed was just spilling out on the bed. That's a situation where the baby's going to be in a high insulin state because they're getting all of this glucose. And when that's abruptly discontinued, the blood sugar is going to fall quickly, and they're not going to have time to have elevated lactate levels, which that's an alternate fuel source for the brain. So while generally we don't want high lactate levels, it can be protective when blood sugar is low. So it can protect a baby from having a seizure or losing consciousness. So that's my big concern with continuous overnight feeds, and that's what makes me want to start cornstarch as quick as possible. But another thing to consider is that I'll show you on another slide. I think it's my next slide coming up. You can actually save a lot of calories by using uncooked cornstarch compared to giving a continuous overnight feed. So using this example of a 12-month-old that requires about 4 grams of glucose per hour, or 48 grams in a 12-hour period overnight. So if you're using a continuous feed with Prosobi formula, you might give 24 ounces over that 12-hour period at 60 mLs an hour to meet that need, and that's going to provide 480 calories. Doing the same thing with uncooked cornstarch, you could put 4.5 grams, or you could get 4.5 grams of carbs from 15 grams of cornstarch, which provides 14 grams of glucose. Argo is 91% glucose. Mix that in 2 ounces of Prosobi, which is providing an additional 4 grams, which gives you a total of 18 grams divided over 4 hours. That same period of time is only going to provide 284 calories. So you're potentially saving almost 200 calories a night. So it could prevent some of the abnormal weight gain that you might see with kids who you're trying to constantly pump them full of sugar so their blood sugar doesn't go low. So talking about kids and teenagers who are a little bit older, I always like to use cornstarch boluses around the clock. When I'm estimating their cornstarch doses and nutritional needs, I use ideal body weight if their actual weight is very different from that. Their diets tend to be very high in carbohydrate because you are supplementing so much cornstarch. So carbs end up being about 60 to 65% of their total calories. And in fact, cornstarch alone can provide 30 to 45% of their total calories. So almost half of their calories could be coming from cornstarch. So that's why it's really important to try to make the food that they eat very nutritionally dense. One thing that I recommend for my patients with type 1, particularly if abnormal weight gain is a concern, is that they limit dietary fat to less than 20% of their calories. Just because fat has so many more calories per gram than carbohydrates or protein, by limiting fat, you can limit calories to some extent. The protein requirements for people with GSD type 1 are just the same as any other kid that doesn't have GSD. So the other types of GSD that are not type 1 we'll talk more about. You can use high protein to treat them, but that's not the case in type 1 because gluconeogenesis is impaired. So nutritional deficiencies can be common in type 1 because the diet is so limited. So you're restricting entire fruit groups, no fruit, no dairy. And so they're at risk for, particularly calcium deficiency, but also some other vitamins. Daily multivitamin with iron is recommended, and calcium and vitamin D supplementation. They're not any more at risk for vitamin D deficiency than anyone else, but it's just such a common thing. And because they have so many other risk factors for osteoporosis, such as metabolic acidosis and potentially inadequate calcium intake, I always do follow vitamin D levels and make sure vitamin D status is adequate. So I get a lot of questions from parents about artificial sweeteners and sugar alcohols, and they are not restricted in any way with the exception of sorbitol, just because sorbitol can be broken down by the body into fructose. But other than that, they can be used to encourage more variety in the diet, and parents just have to be advised that in high doses they can have a laxative effect. So other than that, there's no harm in using any of them except for sorbitol. So GSD type 1B is a little bit different than type 1A. Whereas in type 1A, I showed you on the diagram where you're missing the enzyme glucose 6-phosphatase. So in GSD type 1B, you're not missing the enzyme, but it's just that that enzyme is located inside a compartment of the cell, and the substrate, glucose 6-phosphate, has to get in there. So it gets in there through a transport molecule. And in GSD type 1B, you're missing that transport molecule. So while you're not deficient in the enzyme, the substrate can't get to it. And so you end up with the same metabolic abnormalities, the high uric acid, high lactate, high triglycerides. But you have a few other problems as well that you don't typically see in GSD type 1A. So people with type 1B tend to get neutropenia, and that's not very well understood why that happens. Like, why is that transport molecule important for the development and the function of neutrophils? But it is, and so they almost all get neutropenia. And then related to the neutropenia, they get an inflammatory bowel disease that's phenotypically just like Crohn's disease. So then you have the additional challenge of potential malabsorption because of active inflammatory bowel disease. And that can be made worse by cornstarch. Part of the reason we have to start a little bit slowly with cornstarch in younger kids in particular is that it can be irritating to the GI tract in somebody who's not used to it. So somebody with GSD type 1B who may have inflammation in their gut, that could be made worse by the cornstarch. So typically this inflammatory bowel disease presents in the second decade of life. And one thing that's recommended for most people with type 1B is a probiotic that can help them tolerate cornstarch a little bit better sometimes. So we're going to move on to glycogen storage disease type 3. This one has a lot of different names. It's sometimes called Corey disease or Forbes disease or Corey-Forbes disease or limit dextrinosis. So I mostly call it GSD type 3 because that's easier. And this is caused by a deficient enzyme called debranching enzyme. So debranching enzyme is interesting. So you have an enzyme that releases sugar molecules from a long chain of glycogen, and then once you get down to a branch point where there's just 4 glucose residues left, this enzyme is responsible for removing that branch. And so if you're deficient in that enzyme, you end up with abnormally structured glycogen in the liver. And it tends to be very inflammatory. And so one thing that separates GSD type 3 from other types is that their liver enzymes tend to be the highest. And it might be because the liver is just more inflamed because of the enzyme that's missing. On physical exam, this liver also feels very firm, whereas with other types of GSD, it's pretty soft, sometimes to the point where it can be easy to miss if it's just slightly enlarged. But a GSD type 3 liver, you're probably not going to miss. So coming back to this diagram, you can see where the defect is for GSD type 3 and a couple other types as well. So obviously there are some steps here that were skipped, but I just wanted to make the point that unlike type 1, you don't have a buildup of glucose 6-phosphatase because the enzyme that's missing comes before that step. So you don't have high uric acid levels. You don't have high lactate levels. You do have high triglycerides for a different reason, though. So in GSD type 3, gluconeogenesis is intact. And so, amino acids, lactate, the glycerol backbone of triglycerides, these things can be used to make sugar in the liver, and they are. So when triglycerides are broken down, part of that gets converted to ketones. So while you don't see high lactate levels in GSD type 3, you do see high ketones. So you get a metabolic acidosis from ketone bodies instead of from lactic acid. And because gluconeogenesis is not impaired, you can use protein to kind of serve as a substrate for that. So treating with protein will give a patient the substrate they need to make sugar in their liver, and will decrease the amount of cornstarch that's needed compared to GSD type 1 where you can't use protein. So in GSD type 3, glycogenolysis is impaired, gluconeogenesis is intact, and fatty acid oxidation is intact, which is why you get those ketones. There's 2 subtypes of GSD type 3, but for all intents and purposes, type 3A is far more common. And this type involves both liver and muscle. It affects probably 85% of all people with GSD type 3. So the remaining 15% have type 3B, which would only affect the liver and not affect the muscle. But type 3 is unique among all types of GSD because the 2 places that we generally store a lot of glycogen are our liver and our muscles. So there's all these different types of GSD, and some affect just the liver and some affect just the muscles. And this is the one type that causes both liver symptoms like hypoglycemia and metabolic acidosis, as well as myopathy. The symptoms are variable among individuals. The hypoglycemia can be very severe, in fact, almost as severe as it is in type 1. They also get hyperlipidemia, ketosis, hepatomegaly that I talked about. You can see growth retardation in kids who are undertreated or overtreated. Problems with bone mineral density may be related to the acidosis, may be related to muscle damage. And then myopathy, both skeletal myopathy and cardiomyopathy. The symptoms also vary with age. So in the younger ones, it tends to be more hypoglycemia. And then as kids get older, the hypoglycemia tends to be less severe while the muscle symptoms then worsen. So in childhood, a typical clinical presentation would be enlarged liver, poor growth, low blood sugar, high triglycerides, and then variable myopathy and cardiomyopathy. So you can see things like delayed motor milestones, and if you measured a CK level, that can be elevated even in very young kids. but it may not be symptomatic at that point. So that would just be something that you could use to differentiate GSD type 3 from other types. So generally after puberty, the hepatomegaly improves, as does the blood sugar issues and the hypertriglyceridemia. Sometimes the hepatomegaly improves because the liver is becoming cirrhotic. So cirrhosis is probably more common in GSD type 3 than it is in most other types of GSD that affect the liver. So liver failure can occur. Hepatic adenomas are not as common as they are in type 1, but they can occur in type 3 as well. And then hepatic adenomas can become hepatocellular carcinoma. That's what we always worry about. So the muscle and heart involvement in GSD type 3 is variable from one person to the next. Some people can have asymptomatic cardiomyopathy. Other people can have sudden death related to it. Other people don't have cardiomyopathy but do have skeletal muscle involvement. And again, that's variable too. So we know that it can start early in childhood. We know that based on seeing elevated CK levels in very young kids. And we think that protein can be protective too. So I think the generation of kids now that are growing up with type 3 are getting higher doses of protein than we've ever used before. And so I think that with time we're going to see the effect of that, but we do think that, that it's going to have a protective effect. I'm not sure if I have the slides in here for some case studies that have been done, but it has been reported that just going from a 2.5 gram per kilogram protein diet to 4, so 2.5 is probably already pretty high, but when that was increased to 4 grams per kilogram, significant decreases were seen in CK values and in the thickness of the heart wall in people who had cardiomyopathy. So the dietary management of this disorder is going to depend a lot on age and the symptoms that they're having. So in younger kids who are primarily having low blood sugar, metabolic acidosis, they're going to need probably regular doses of cornstarch, maybe almost as much as somebody with type 1. Even the young kids that are having hypoglycemia should be started on a high protein diet to protect their muscles and to provide substrate to keep their blood sugar normal. And then beyond that, you actually want to use the minimum amount of cornstarch necessary to maintain normal blood sugars. So it's believed that the cardiomyopathy is affected by excess carbohydrate. So it's like the myocytes are storing glycogen just like the liver stores glycogen and becomes enlarged. So you want to limit the amount of carbs that are given to just as much as is needed to maintain normal blood sugar and prevent lows. But you want to be very careful not to give excess. I think excess carbohydrates in this type of GSD is potentially a lot more dangerous than any other type. So protein in this disorder can be used as an alternate source of glucose because gluconeogenesis is intact. We think it may improve muscle function by enhancing muscle protein synthesis, and it might prevent excess glycogen storage in the liver and potentially in the heart because if you increase protein, there may be just naturally a decrease in carbohydrate intake from that. So the amount of protein that we use in type 3 is higher than any other type that uses protein as part of its treatment. So for most patients, usually more than 3, up to 4 grams of protein per kilogram of body weight per day in divided doses. It's really difficult to get this amount of protein from food for most people, and especially for kids who tend to prefer a high carbohydrate diet. So protein supplementation is almost always used. So what is high protein? That's going to depend on what you read. I don't know if there's a standard definition for that. 0.8 grams per kilogram is the daily recommended intake. According to the Institute of Medicine, the acceptable distribution of calories from protein in a diet is 10 to 35%. And it's probably generally accepted that high protein might be considered greater than 1.5 grams per kilogram per day. So we're talking about using doses much higher than that in people with GSD type 3. And a lot of people are concerned, rightly so, about the potential negative consequences of this. In particular, people are worried about kidney function. While we know that people who have existing kidney disease that can be exacerbated by high protein diets, there is not evidence that suggests that giving high protein to somebody with normal kidney function will cause any problems. So it's generally thought that changes in renal function that might be observed are probably an adaptive mechanism. So cornstarch therapy is using the lowest dose possible, and that's probably going to be higher in childhood than it is in adulthood. I have a number of adult patients with GSD type 3 who don't require any cornstarch at all, or maybe just require a small dose at bedtime. If you do see any older patients, particularly any women who get pregnant when they have GSD, they do tend to require cornstarch if they didn't before, and if they did before, then doses tend to increase during pregnancy. So that's one thing to keep in mind. But you want to not give any more than is necessary, mostly because we think that excess carbs promotes cardiomyopathy. It might be typical to use somewhere between 1 and 4 doses per day. And if somebody needs 1 dose a day, it's probably at bedtime to get them through that overnight period of fasting. There are some patients who do require a middle-of-the-night cornstarch dose with type 3, particularly younger patients who have higher requirements for cornstarch. And if that's the case, these patients also do very well with glycosade. So with any type of GSD, there's risks associated with both overtreatment and undertreatment. But with type 3 in particular, we're far more concerned about overtreatment compared to the other types. But still, with any type, overtreatment can cause excess glycogen storage, abnormal weight gain, and insulin resistance. And then, of course, with undertreatment, we worry about the low blood sugar that we're trying to prevent. The sugar restrictions in GSD type 3 are not as strict as they are in type 1 because fructose and galactose are utilizable sugars in this disorder. Patients don't have to pay particular attention to what type of sugar it is they're consuming. However, it's still recommended that total sugar be limited to less than 5 grams per meal. And then snacks less than 2.5 grams per meal. And that's to prevent excess storage in the liver and the heart. And the other thing that we worry about is most likely these patients are going to have a normal insulin response. So taking in concentrated sweets or high amounts of sugar is going to cause them to release a lot of insulin and potentially have a rebound low because of that. So most of my patients, all of my patients with GSD type 3 have both blood sugar and blood ketone monitors. And so ketones can be elevated even in the setting of normal blood sugar. And so sometimes I think following ketone measurements is even more important than following blood sugar, because if gluconeogenesis is upregulated, the hypoglycemia can be blunted, but you might see elevated ketones that lets you know that this person is probably relying on gluconeogenesis to keep their blood sugar normal. So that can still be an indication that you're going to want to make some adjustments with therapy. So while a normal blood sugar is probably above 70, for most of my patients I ask them to use a target of 75 just to give a little bit of cushion, because we don't trust meters as much as we wish we could. My goal for the ketone meters is to keep all of their ketone levels below 0.3. Generally I have them check when they wake up, and then before each protein cornstarch dose and before each meal, as long as a couple hours has passed in between. After I see them, I have them do this for a few days at home when they're in their own environment to make sure that the normal levels that we were trying to achieve in the hospital are still happening at home. And then after that, I just ask them to check about once a week, multiple times throughout the day, so that if something changes as far as like somebody's having a growth spurt or their activity level changes, we'll be able to respond to abnormal numbers before they get too abnormal. So there are guidelines for the management of GSD type 3 that were published in 2010, and these are readily available on Google. You can Google GSD type 3 management guidelines, and it's the first thing that comes up, and anybody has full text access to this. So this is really incredible. This was the first type of GSD that American College of Medical Genetics published guidelines for. And actually just recently, guidelines came out for type 1. Guidelines for type 6 and type 9 are under review right now, and then probably guidelines for type 0 will be in process after that, but that hasn't even started yet. But this is available to anybody, so it really covers everything from diagnosis to all aspects of management. It's fairly readable. I would say most of my patients with GSD type 3 have a copy of this and hopefully understand at least part of it. But it's really fantastic that, that this is out there, and I wanted to make you guys aware of that. Okay, so we're going to move on to GSD types 0, 6, and 9. And when we talk about these, we can sort of lump them together because they're very similar in a lot of ways. We consider these like the milder types of GSD. Compared to type 1 and type 3, which can have very severe hypoglycemia, these tend to not be as severe, although there is variability within them. So they usually present as ketotic hypoglycemia. And I think probably a lot of these kids are followed by endocrinologists and given a diagnosis of ketotic hypoglycemia and told that they'll grow out of it one day. But I think sometimes these symptoms can be mild to the point where it's a misdiagnosis. And kids often do seem to outgrow it because symptoms become even more mild once growth is complete. They still can have long-term complications if they're untreated or undertreated. They tend to have delayed puberty and delayed growth, and some of them end up short overall, so many of them don't catch up. They can have osteoporosis, and in some patients in type 9 in particular, cirrhosis has been reported. So coming back to this diagram, you can see type 6 and type 9 are kind of in the same place as type 3. So unlike type 1, you're not going to have elevated lactate and elevated uric acid. You will have elevated triglycerides, but not because of that fatty acid synthesis pathway. And then with type 0, that's on the other side. So GSD type 0 is a problem where you're missing the enzyme needed to make glycogen. And so two things that separate this type from other types is that it's the only one that doesn't have a big liver because there's not excess glycogen stored there. And then you can have postprandial hyperglycemia, possibly because the glucose isn't being stored in the liver as it normally would be. That's also something that's easy to miss if you're not checking blood sugars postprandially, but that's what separates 0 from type 6 and type 9. But they will all give you ketotic hypoglycemia and are fairly mild. So as with type 3, in these types, 0, 6, and 9, gluconeogenesis is intact, so you can use high protein to be part of your treatment, and because of that, you require less cornstarch than you do for type 1. Starting with type 6 and type 9, these two are clinically indistinguishable from each other. So type 6 is where you're missing the enzyme phosphorylase, hepatic phosphorylase, and type 9 is where you're missing phosphorylase kinase. So it's kind of like the same enzyme system working at the same part of the pathway of glycogen breakdown. And so they look exactly the same. But one thing to keep in mind is that there are multiple subtypes of type 9, And the one that is most common, affecting probably 80%, is X-linked. So you generally see boys affected. And in fact, that X-linked form of type 9 is the only one of these that's not inherited in an autosomal recessive manner. So sometimes when I see a boy with ketotic hypoglycemia and maybe a slightly enlarged liver, I would think type 9 before type 6, although the incidence of type 6 is equal in boys and girls. Now, if I saw a girl with the same thing, ketotic hypoglycemia and the liver slightly enlarged, I would think type 6 before type 9, just because type 6 might be more common than the rarer subtypes of type 9, if that makes sense. So type 0 is where you're missing the enzyme glycogen synthase, so you can't make glycogen. There's a decrease in the glycogen content of the liver, so you don't have hepatomegaly. In most patients, it's not a complete deficiency of this enzyme. So if you did a liver biopsy, you wouldn't see absent glycogen. It would probably be just slightly reduced. But another thing besides the normal-sized liver that separates this disorder from type 6 and type 9 is the postprandial hyperglycemia, and they would also have elevated lactate levels postprandially. But again, that can be hard to catch sometimes. So type 0, 6, and 9, while they can be a little bit difficult to tease out which one you're dealing with without genetic testing, the good news is that they're all treated the same. So the goals of managing these disorders is to prevent hypoglycemia and hyperglycemia in the case of type 0, and to prevent ketosis. In infants, that is often achieved with frequent feeds, and they may not have many symptoms at all. With children and adults, it's a little bit variable, particularly with type 9. There's some patients with type 9 that have been pretty severe to the point of having evidence of fibrosis, hepatic fibrosis, at the time that they were diagnosed. But many kids are barely symptomatic. And so treatment is going to be, in general, high protein, usually 2 to 3 grams per kilogram, and a variable amount of cornstarch. Most of them, especially younger kids, will require at least a dose at bedtime and up to 4 doses throughout the day. Many older patients with these disorders just do well on high protein. So 2 to 3 grams of protein, as I mentioned. These patients don't need as much protein as people who have GSD type 3, because you're not trying to prevent muscle breakdown in this disorder. In these disorders, they don't have the enzyme deficiency in the muscle like type 3 does. The dietary sugar restrictions are similar to type 3. They don't have any specific limitations on what types of sugar they can have. But for the same reasons as with other types, you want to limit total sugar. Because in type 6 and type 9, it would contribute to excess glycogen storage and make the liver bigger. In type 0, it would cause postprandial hyperglycemia. So the hyperglycemia in type 0 never requires insulin. It generally can be managed quite easily by limiting sugar in the diet. And then with both of those types, we do worry about the rebound lows from insulin effect. And so that's the other reason to limit sugar. Patients with these disorders don't necessarily need a multivitamin because their diet is not terribly limited and deficiencies aren't expected, but because they are potentially prone to metabolic acidosis and maybe at increased risk of osteoporosis because of that, you want to ensure adequate calcium and vitamin D intake. Let's summarize what we've talked about. So type 1, these patients require the most cornstarch and the most frequent dosing, generally about every 4 hours, starting at 6 to 12 months of age. Glycosate given at bedtime can give patients a full night of sleep, many of whom have not had that for many years. Their diet is naturally very high carbohydrate just because of all the cornstarch that you give them. So up to 65% or sometimes more than that coming from carbs, including cornstarch. They have the most strict sugar limitations, completely avoiding fructose fructose, sucrose, lactose, because they can't use galactose and fructose. But their total sugar is still going to be limited to less than 5 grams per meal. They require the RDA for protein, and limiting fat in their diet can be a way to cut calories and prevent excess weight gain because of all the empty calories they get from cornstarch. When you're estimating their energy needs to try to calculate starting doses for cornstarch, use ideal body weight if actual body weight is very different. And you always want to give these patients a multivitamin, calcium, and vitamin D if they're not getting adequate calcium from their diet. For type 3, these patients get the highest amount of protein, up to 4 grams per kilogram per day, and sometimes even higher than that. Complex carbohydrates, including the minimum amount of cornstarch necessary to prevent hyperglycemia, but not more than that because it can contribute to hypertrophic cardiomyopathy. Glycosade can be useful at bedtime if overnight hypoglycemia is occurring, and limiting simple sugars without necessarily paying attention to the specific types of sugars. With type 0, 6, and 9, they also do well with a high-protein diet, not necessarily as high as type 3, but 2 to 3 grams per kilogram per day, and a variable amount of cornstarch just depending on their symptoms, their blood sugar levels, and their ketone levels. Again, with these types, glycosade will be helpful if overnight hypoglycemia is occurring as an alternative to giving a dose of cornstarch in the middle of the night. And limited simple sugars without specific restrictions on any types of sugar. This is my contact information, so I welcome emails, phone calls. If there's anything I can do to help with any of your patients, I'm more than happy to do that. Thank you.
That was really great.
Did I go over?
No, you perfectly.
Okay.
So,
is there time for questions?
but if anyone has any pressing questions right now, please feel free to use this time.
Do you ever recommend or have you used continuous insulin monitoring system?
I do. So I mentioned that I like to admit patients, and I'm actually only able to do that for patients up to age 26. So for the adults that I follow, I see them as an outpatient in my clinic. And I use continuous glucose monitors in them, like the iPro. I'm not sure if you're familiar with that. It's blinded, so it's not something patients are going to respond to the numbers. We just download it and we see what patterns are happening. So I found that to be very helpful in many cases. I don't know how accurate it is, and I can tell you that's actually something that hasn't been well studied. There are some studies that have looked at continuous glucose monitors compared to finger stick blood sugar monitors, but that's not a great comparison. So I have a study that is undergoing IRB review right now, where when I have these patients in the hospital and we're measuring like serum blood glucose values, if we put an iPro on them, then we can really see how accurate is it. So hopefully that's something that I'll be able to answer better soon. But it is something I do for my adult patients now because I feel like it's the best that I can do. Yeah.
Have you had cases where you've not been able to reliably give them a specific subtype diagnosis, and if so, what do you do with them?
Yes, a lot. I would say it's most common with these milder types, type 0, 6, and 9. When I narrow it down to one of those 3, or even just 6 or just 9, I think it's cheaper to do the whole panel at Baylor. And so often it comes back negative. And that's incredibly discouraging for the families. So I try to explain that even if we don't have a genetic diagnosis, all we're really doing is treating symptoms, right? We know the blood sugar's going low, we know the ketones are going high, and if we can use cornstarch and protein to fix that, and he's growing well, then we can call it a clinical diagnosis because they need a diagnosis, and the treatment is working. So that does happen quite a bit. One time it happened with a type 3 patient. Like, CK is through the roof, and AST, ALT are very high, big liver. It was very, it couldn't be anything else, and genetic testing came back negative.
You treat it that way anyway, right?
Yes,
Yeah.
yes. Yeah. Yeah, so I don't do anything different with treatment. I understand it's a really difficult thing for the families to not get the answer that they were hoping for.
So no one's doing liver biopsies anymore, the diagnoses?
I try to avoid that just because it's invasive.
No, I know.
And, you know, with the exception of type 6 and type 9, I feel like these disorders are all different enough that you can get an idea of what you're dealing with clinically based on blood tests. And then, in a perfect world, genetic testing would support what you found. But yeah,
So does Baylor run all of these?
Baylor has a panel that looks at every gene that causes like every type of GSD. So in somebody where I feel like this is definitely type 3 because CK is elevated and severe hypoglycemia and, you know, other things, then I might look at just that gene. But oftentimes it's like I'm narrowing it down to type 6, type 9, but maybe it's 0, there was a high blood sugar somewhere, you know?
Thank you so much.
Thank you.